Alrighty, hello everyone, and welcome to another session of Virtual Global Spine Conference. Thank you for joining us this week. We appreciate everyone who's able to make it, and it's always great to see a lot of familiar faces among the participants. Just as a reminder, many of these, almost all of them, are recorded and uploaded to YouTube, usually in within a week or so. So you can always have a chance to catch up on the ones you've missed there. Today, it's my pleasure to host a special session with our panelists. Several months ago, we decided to kind of team up with four excellent spine surgery colleagues who have always been passionate about education, training, and spine surgery, and they've been really instrumental to virtual spine over really the last many months. But more recently, we kind of got them as a group together and asked them to help us in a more formal way. So I'm very happy and honored to welcome them today, at least three of them. Dr. Selby is unavailable today, but I'm honored to have Dr. Mamagani, Dr. Galgano, and Dr. Goodwin with us. And they will present cases today. So today's a fun kind of what we call family cases of interesting cases, complications, and as usual, open dialogue, open discussion, and lots of critiquing and asking difficult questions by the hosts and especially by me. So welcome everyone. We'll start with Dr. Mamagani. Welcome, Alex, and thank you for presenting a case. I know you're in Switzerland and it's always around midnight there or thereafter. So welcome and thank you for joining us.
Yeah, thank you, Ali. Thank you for giving me the opportunity to show my complex cervical spine case. I'm an orthopedic surgeon here in Switzerland, and I want to show you a case I operated on 5 years ago. And I always start with this blue slide. And if I go to the next slide, you will see this is a lumbar spine. This is the same patient. This is his lumbar spine, just to give you an appetite. So I have nothing to disclose for this case. Also, I'm a consultant for these two companies. The clinical presentation was very difficult for all of us. There was a 77-year-old male patient. He was a widower. He had two kids, and he was working in the garden. Then he fell, and he couldn't move any limb. So arms, legs, everything was plegic. He was tetraplegic. He was able to shout. The neighbors helped him and they called the ambulance, and now the patient was transferred to the emergency department. But during the transfer, the motor function came back. And in the ED, it was totally back again. But he was tetraplegic in the beginning. And the sensory function was altered still, and it was changing. It was some kind of pain in the left leg. It was hyperesthesia in the right. He had a level at C5. He was never hemi or para. It was always a tetra symptomatic. And he had some weird additional symptoms like vertigo and nystagmus, and he was not feeling really good. He had had some hyperreflexia in the left leg, and he was always conscious. He was never altered. He was always Glasgow Coma Scale 15. But what we was not having before the trauma, it was neck pain. He has never had neck pain before, and now he has got a new onset of neck pain. So some diseases he had before, but nothing relevant to this case. I want to mention again, no history of neck pain or arm pain. The patient was sent, of course, not to spine surgery because everybody thought, well, nystagmus, vertigo, this must be some kind of stroke. And so he was transferred to internal medicine neurology, and then they ruled out everything. But then they found a CAT scan, very interesting things on the cervical spine, and they asked me to have a look after the patient. Again, he was able to walk, he was able to use his hands again, but he has had a sensory function disorder, very hard to describe here. This was his cervical spine, and you see there is something not really normal. Does anybody want to take the opportunity and describe what he sees? I can show the next slide.
I think Matt Goodwin should describe it. Come on, man.
Matthew, what do you want to see? Both at the same time, or AP or lateral?
Oh, I don't care. You know, I'm always happy to talk. Yeah, so on this view, he certainly looks like he has some unusual anatomy through 2-3. It almost looks like he has an autofused or congenital anomaly at 2-3 that looks just ends up looking like a big 2 here. So very unusual anatomy here. I'd want to obviously see a CT to have a better look at this.
Yeah, it's very easy. I heard congenital, and in the chat box, the term is suddenly there, and everybody knows this really rare disorder when you're in spine surgery. But this will get a little bit more difficult.
Yeah, let's before we move forward, Alex. So I agree with Dr. Goodwin. He has congenital autofusion of C2, C3, and I think and then 5-6, I think they're autofused as well. So this qualifies as a Klippel file. I'm not sure even if the C1 is fused to the occiput as well. So multiple lung lever arms, making the situation of adjacent segment disease plausible.
Yeah, thank you.
To further say, add to Nader, what he just said was that in the posterior elements, I think you have some additional fusions. You probably have everything fused here, not even just across the disc bases, but across the, the posterior elements and the skull base as well.
Yeah, and the most difficult part is the counting. You say 2-3 is fused, it's ankylosed, it's congenital. If you see the posterior process, the spinal process, and if you have a look, what level would this be? Which vertebra would this be?
I'm going to guess 4.
It's 4. Yeah, I agree, but the radiologist first said 3. So it's typical. You have to look very carefully. So this is the CAT scan. You see, it's a CAT. It's an angio CT because it was a stroke protocol, and I was happy about this to see the vertebral artery. And in this coronal view, you see there's a scoliosis, there is a fusion or ankylosis. No, it's a fusion C2-3. There's no disc space here. You can see C5-6 is fused 2, C4 is a solitude vertebra, and counting is, as you said, Nader. You posted something about embryonic in utero segmentation several weeks ago, how important it is to know embryology of the spine. And this is the coronal slide. You see, it's hard to find all the pedicles again. There are some massa lateralis used too, and it's really hard to count. This is a sagittal view. Again, the same findings here, ankylosed or fused vertebra here. The vertebral artery does an exciting and amazing loop in the foramen, which I thought first would be a nerve root foramen, but the vertebra makes a funny loop here between C2 and C3, which makes it hard for me to judge whether I can place a screw in the isthmic region or in the pedicle. So you see this loop on the left side in the foramen, and everybody here in the faculty always says, or in the panelist, do a CAT scan in complex cervical spine, and can see here very nicely how important it is. The screw placement, irritating a nerve root could be survivable. An irritation of the vert can lead to stroke and a fatal outcome. So this is the 3-dimensional reconstruction. I hope is I'm able to show the. No, I can't do it. No, I can't. This is you see hypoplastic massa lateralis. You see nothing around the vertebral artery here. This is not normal. This is really weird. You have some loops here through these foramen. It's really good to have a CAT scan angio here. So what we find here is a condition, and what is the most important condition for you as a surgeon? Is this the ankylosing disorder? Is it degenerative disorder? Is it congenital disorder? What are you suffering the most of as a surgeon if you treat these patients? Has anybody fear of congenital disorders, or do we surgeons always say, no, I can, with imaging, I will find everything I want, I need, and this is safe for me? So for me, it is a clear D. It's really hard for me. I think this is complex, and this is hard for me. And I would not say, ankylosed disorder is not a topic, because Nader mentioned the lever arms are high. Ankylosed spines are more difficult to treat. And the degen component is hard because maybe it's causing the symptoms. Congenital is always hard for me because I don't find them quite often. So this is some Excel views with this loop. You see here, hypoplastic mesolateralis C56. You can hardly find any pedicle here big enough for a pedicle screw, but the mesolateralis here, I don't know whether you can see my arrow, this laser pointer is difficult here for treatment. These are the CAT scans, and before I come to the MRI, is anybody interested in the MRI, or do you see the diagnosis even yet on the CAT scan? You know, there was a time we have had no MRI, maybe not one of us, we are all grown up in the MRI era, but myelography would be here the standard go. Does anybody like to make a judgment? Where is the problem?
Alex, I was just going to say real quick that, if this patient came in trauma, clinical picture that is concerning for incomplete spinal cord injury, central cord, and I see this and there's a contraindication to MRI, I'm not going to get a CT myelo. I'm going to take the patient to the OR for a posterior cervical decompression. But as it comes up a lot in these conferences, at most facilities now, most institutions, if there's no contraindication, we can get an MRI quickly. I would get an MRI on this patient before I take him or her to surgery. But if that wasn't the case, I would not do a CT myelo on this patient with an acute, potentially incomplete spinal cord injury. I don't know what the others feel.
Wait, so Ali, why not? Why wouldn't you get the myelo? Just it's unnecessary information to know the degree of cord compression, or?
Well, no, I think the myelo is I would get the myelo in a degenerative, like in the degenerative state, or somebody's coming in with degen spine, but somebody with an acute trauma, severe stenosis, and what appears to be probably cord compression, and clinically I can localize the level, I would probably take him for a decompression and not do a CT myelo in this case. If there was disconcordance of the exam and the CT findings, then that's probably when I would do a CT myelo. But
so it would just be somebody with congenital. This could have been an older person with degen with this degree of canal stenosis, or it could be someone with OPLL. You would have the same reasoning for all those, not just congenital. Is that right?
Yes. Yeah.
You're saying time-wise.
Okay. So I can show you now the MRI. This is a T1. Wendy, can you as a neuroradiologist say, is T1 useful in trauma in these questions in spinal cord imaging?
I mean, you can see that there's something abnormal going on you don't have any CSF space, which is blacker than the cord, both at the level of compression, which was 4, and below that.
Yeah.
But
you won't be able to see the Ali Barge view. This is the last view I will show you. What would you like? Would you like to have always a steer, a term, time and version recovery sequence?
Yeah, the stir would be the most helpful, yes. But even T2 would be okay.
Yeah. If you ask for it. Now it's getting a little bit more complicated, and I need a lot of help. Now I see some set changes which I didn't expect when I was looking at the CAT scan, because I thought, it's like Ali said, it's 4, 5, 3, 5. It's this region. Maybe it's the problem. But now, can you make a suggestion? What can we see here?
For me again, this is not the result of trauma from like a dinged cord from that fall at that narrow level. This is way more extensive. You've gotten a well-established syrinx down below that level. So maybe I don't know. So the top looks a little hazy, like it could still be edema kind of up near C1, 2. But at the bottom aspect of this, that's definitely been there a while. And then below the T2, the bright T2, at what level? Let's see, 1, 2, 3, 4. What's that, 7 or 1?
The contrast?
Yeah, we could get contrast. It does look like you have something unusual below the syrinx. It looks like a mass or blood, possibly.
This is contrast.
So
this is contrast. It's contrast-free, except of T2. There in the region you mentioned last that there is something going on as well. And in the axial view, we see the contrast is not really easy to describe. It's like posterior, anterior, a little bit more on the right side than on the left side. But it's a contrast enhancement really here too, far away from the maximum narrow spinal canal. And this is the T2 Sag View, and I guess Ali would love to see, because this is the most important view for you, isn't it?
Yeah, I like the T2. I like the T2 a lot. A mid-sagittal T2 usually, tells me a lot about whether I need to intervene urgently or not. But my question with this case, Alex, goes back to the patient's presentation. They were fine before a trauma, and then after the trauma, they became tetraplegic or paraplegic?
Yes. He couldn't move for approximately 15 minutes, 20 minutes, and the neighbors found him unable to move. And then the motor function came back within 30 minutes. We have short ways. The ambulance is really...
Back to full strength?
Yes, he was able to walk, he was able to use his hands, eating, making everything on his own. He was not plegic, there was no this anymore, but sensory loss that hasn't been there before.
So it was a lucky coincidence that he fell down and dinged his cord so that he could come to attention. Is that right? Mm-hmm. Alex, there's one more thing. Is there also an acute disc there above the level of the mass ventrally? Whatever level that was, 2,
no,
3,
no,
4,
it isn't.
5, 6,
it
7,
isn't.
1, 2.
It's just, I think it's a void. It's you can't find it in others. There was no disc herniation in these images. We can see it later on.
Oh.
Thank God for MRI in this case, right? Because imagine if you didn't have the MRI and say the patient had a contraindication to getting, had a pacemaker or something. I mean, there's no way it would be able to know this on a CAT scan alone.
Yeah.
This is a great case.
Thoracic spine with and without contrast too.
Yeah, I mean, Alex, this is an impressive, super nice case. It's like a, what's next, and it's a surprise. Like I should have thought about that, because you're presenting the case. It's always like expect the unexpected. So because initially, the thought process was, okay, this guy has Klippel file, he falls down. And usually you'll have stenosis above and below the autofuse segments. That's the usual case, above or below or both. And then you get a central cord. And my initial thoughts were, okay, if there's no spinal instability, like there's no 3-column injury or anything like that, then certainly you can work this patient up, especially when he's neurologically improving, and see where the contusion is. But this is very unexpected. I mean, this guy, we're dealing with a syrinx with an intramedullary process. And it's just now it's like puts you on a different dimension. Like it's just steers towards a different path. You're not dealing necessarily with central cord. You're dealing. I mean, maybe you are, but it's not due to pre-existing spondylosis. It's just to pre-existing an intramedullary. It's an intrinsic process as opposed to an extrinsic process. So, I think definitely, the next step would be just speak with a radiologist. What do they think this is? Is this is it an intramedullary? I think it is because of the syrinx. And what's the differential? You put it in that compartment. You think of, ependymoma, hemangioblastoma, and then less likely astrocytoma, maybe GBM. What are your thoughts, guys? This is an excellent case.
Before anybody goes on to what they think it is, so I want to follow up on what JR just said about the CT. Actually, and I think he just said 2 different things, and I'm going to disagree with one and agree with the other. So he said you couldn't see this on CT, I think. just for a point, if you ever can't get an MR, if you get a CT with contrast, we definitely could have diagnosed this on that. We couldn't probably tell the details, but we definitely know that there is a mass expanding the cord. So that would have been better than nothing and better than a non-contrast CT. So CT with contrast, always helpful.
Yeah,
and
but what I meant by that is that that's not you don't typically order a CT with contrast with trauma, but you do get MRIs with trauma, right? So,
but I'm saying, you know that though, we've talked together and talked where I say, make sure you get the CT with contrast if that's your last resort. And I thought that's what you followed up saying, but I couldn't hear the end of what you said. And that was just my advice to the people here. If you ever can't get the MR, that was just that point.
Okay, I just speed up a little bit because we're running out of time. And so you see, there are 4 things I want to highlight. This huge edema running far above to C1. We have got this narrowed canal, mainly in 4-5 level. We have got this syringomyelia, and we have got this weird structure with contrast enhancement. And so I need help. Like Nada said, talk to the radiologist. And it's hard for me. My question is, what do I see? Do I see spinal cord injury? Do I see intramedullary neoplasia? Is this a tumor? Nada, you mentioned it, Ali. We know is this a congenital disorder, but is this intramedullary problem as well congenital, or is this due to the trauma? Maybe not, because the patient is able to walk again. Or is everything a cervical degenerative myelopathy? And what does my neuroradiologist say? They say it's too old for primary intramedullary tumor. It's not excluded, but it's not common. And the edema and the narrow spinal canal, the atypical contrast. And I've got a very, very experienced neuroradiologist here, and he said he has seen this in the Klippel-Feil syndrome, pre-existing Klippel-Feil syndrome, in a similar case, and it was just myelopathy, cervical spondylotic. He's had a contusion of the spinal cord, but the neurology came back. And the Klippel-Feil syndrome is rare. One of 40,000 newborn has got this. It's maybe in the 3rd or the 8th week of gestation, the problem occurs. We have to know and remember embryology, and it's defined if 2 or more vertebrae are fused or malsegmented. And the Klippel-Feil syndrome and myelopathy, if you go to PubMed, you don't find lots of publications. It's like today it was 137 articles and 1 review. And the review was published 2017, 1 year after the patient was admitted to my emergency department. So I was not able to read this. This is for Michael Feelings. He made an analysis, and he has seen that the prevalence of myelopathy is much higher if there is a congenital cervical fused situation or when there is a Klippel-Feil syndrome. You see, this is an image from his wonderful publication. And if you want to classify Klippel-Feil, you can go back to 2006 when Dino Zamatzis has published this classification. I don't want to go into depth here. So this is my patient, and I asked my neurologist, what does he have? What is the patient suffering from? Where is the lesion? The neurologist said it's not typical myelopathy. It's atypical. The patient has got polyneuropathy as well. He could measure it. Everything was weird, but he said, the neurologist said it must be something on C5 level. And so I asked my colleague from neurosurgery, what would he do? Would he go intramedullary as well? What would he do? And so these 5 options, A to E, would somebody said, I leave it alone, I just make a follow-up conservative treatment. But the patient said to me very clearly, I don't want to experience this horror ever again. I don't want to be tetraplegic. And can you give me a good guarantee that this will not happen again if I just continue living this? And this is really hard to say, no, it happens only once, and the next fall, it will not happen again. So there's likely a high risk that this will happen again. Maybe it will worsen. Maybe now the trauma makes some instability. what would you do? Just decompress? Would somebody go from anterior with this MRI to decompress only for 5, or long fixation from posterior, like Ali mentioned in the beginning, or would you go intramedullary?
Hey, Alex, while people are putting in their votes, can you show, so you told me there was no disc down there by where you're saying that enhancement, the cervical spondylitic myelopathy would be the enhancing part that's down in the lower cord, like a T1-2. And it looks to me like there's a disc there, and you need some inciting event to have cervical spondylitic myelopathy, some kind of compression, right? So that I think would influence your answer if that is true.
Yes, but the level would not fit to the neurological findings. It would be too low for any problems in the arms. And so this is what your clinical findings and the radiological findings, it doesn't match. Like this contrast enhancement T2, this had no influence to the arms. It must be somewhere a problem at C5. Whether it's the edema running high or not, it's hard to say. And the neurologist said only sensory function loss and recovery from posterior, maybe it's only myelopathy. Maybe it's a posterior cord compression, and the tetraplegic was just a shock, a spinal shock for 30 minutes.
Hey, Alex, what's the, so everything comes back 5 out of 5. And then what's a little bit of hyperreflexia, and then what's the sensory exam?
Yeah, it was hyperreflexia only left leg, and hyposthesia. It was distal hyposthesia, the fingers, the arms. It was a numbness. It was some tingling and some kind of dysesthesia.
Yeah.
And do they have a lot of pain besides their neck pain, or no?
Yes, new onset, no, only neck pain, no radicular pain in the arms, only neck pain.
You know, here are my thoughts.
Yeah,
I mean, I think this is a fantastic case because we're dealing with 2 different pathologies and that are treated differently, right? Like, you know, I think there's an intermedullary process. There's no doubts about that. And then you have a process of central cord syndrome, probably due to pre-existing myelopathy. Now, like treating central cord, like you have a patient with central cord syndrome, no fractures. That's in the setting of spondylosis, you know, be it Klippel file or degenerative disc disease. You know, it's like, okay, they get better. There's no emergency, but we know that surgical treatment is better than non-surgical treatment, right? Like long-term, like that's all level 3 evidence. On the other hand, if you have this guy who comes to your clinic with this intermedullary lesion and he's intact, most of us probably will treat it conservatively and follow up. So I think, I don't know, I don't think there's a wrong or right answer. You know, I know what I would do after thinking about it here for a little bit, but I'm wondering what would other people do for this patient before, you know.
Just for the sake of time, while you guys talk, while we get other opinions, Matt, do you want to go next? Yep, I think Dr. Goodwin's going to show his next case, and while he pulls that up,
yeah.
What do others think? That's a really good point, Nader. They're almost 2 different pathologies.
Yeah, I would think, you know, to be honest, like if this patient comes to my clinic, you know, with an intermedullary lesion, you know, and he's almost asymptomatic, I will just watch it and then pull the trigger if it grows or if it starts having symptoms. You know, that's, you know, it's all risk benefit. And you know, I mean, I would probably with this patient go with A and watch it and have him get better and treat his neuropathic pain because he's neurologically doing okay. But I don't know if that's right or wrong answer.
This was good because we have a long discussion, and you know, the internal medicine always says don't go for surgery, but the patient said he's so fear to lose his ability to live independently, and so he said I would go for surgery. And I just go for the solution. This was the laminectomy C4-6. You see implants inside, but this is the laminectomy. And you see, this is 3 months later. And this is a change of the signal iterations below the stenosis. I did C4-6, 3-level laminectomy and fusion. Edema went back, and the syrinx went back. And this is the 3-year follow-up in 2019. You see the date up there, and this is 3 years later. And what I did was just decompression and fusion, long segment fusion. And I was not able to go to T2. So I made this weird cerclage with 1 millimeter cerclage as a solution because I don't want to just two screws
I'm sorry,
in
Alex,
C3.
I'm so sorry. I think we changed the screens already. So you operate on him, and then at follow up, what did the images show?
Sorry, just the edema went back, and the findings, the serings went back. Everything was really much better, a lot better now. And the patient
the
was
laminectomy fusion, and the signal improved.
Went back. Yeah, I will show you on Twitter. I will post the post-op on Twitter, and then you can find it there.
Wow, that's really interesting. Great. Wow.
So it was degen, or it was you didn't do anything intramedullary.
No, we didn't go intramedullary. My neurosurgical colleague said no.
Cervical spondylolytic myelopathy can look like a mass and enhance like that. So that's what it was, right? Down at that level. So he didn't need to go intramedullary for that. Now it's kind of the point of the compression down at that level. That's why I was asking about that. Because that can be a fool or a mimic of tumor.
Yeah, it was mimic of tumor, right?
Well, that's definitely a great case. Thank you. Thanks, Alex, for kicking that off with a very straightforward and easy case.
Sorry for the time.
Our next guest is our another one of our terrific virtual spine panelists, Dr. Goodwin, Matt Goodwin from WashU in St. Louis. Matt, thanks for joining us. You can unmute yourself and let's see what you got.
Yeah, thanks for having me. Wow, what a case. Mine is not going to be the same. It's a little bit more, I think, a little bit more back to the basics, but I think it makes a reasonable point. And we'll try to get through it so Michael has a little time for his case. So this is a 23-year-old. She's got a large back spine mass. She's diagnosed with FAP and has multiple colon polyps about 2 years ago. She comes to me because she's got back pain, and then she's 3 to 4 out of 5 in her hip flexion and knee extension, and she's got paresthesias L2, 3, 4 as well. So I don't know if these might be a little bit small here, but she's got a very large paraspinal mass that's pushing on L2, 3, and 4 and encroaching into the foramen, and also there you go, also eating through the bone as well. So saw her in clinic, talked to her, legs getting weak, a lot of pain, etc. Plan to resect this thing, plan to do T11 to L5. I'll move it along through this part so we can get to the more interesting part. Resected the tumor and the pedicles off the left side at L2, 3, and 4. And then if you look at the images, clearly you're going to have a tissue defect on this left side because I took this with the muscle around it. So I involved the microvascular team to do a free flap.
Matt, I'm sorry if I missed this. Did you biopsy it, or did you know what it was going in?
Oh yeah, biopsy. Oh yeah. I'm very conservative, I think, with my tumor workup. So yeah, I definitely biopsied this. And because it's not to get off on the desmoid thing, but because it's desmoid, I mean, I'm probably saw her more than once, trying to not operate, thinking, giving her, because she's got multiple desmoids throughout her body. So, but this one had, was having trouble walking and kind of had reached the point where it didn't have a lot of options. So the tumor was really big. So we resected it, and we resected it with the bony elements as well. And so here you see the pedicles gone at 2, 3, and 4. The nerve roots are free. Here you see we've involved our colleagues to do a flap for us. Here's the specimen afterwards, a very large specimen, but went really well. I chose to stop at L5 because she's young, and I wasn't really stoked about, and she's going to live, and I wasn't really stoked about hooking her up to her pelvis. And so I wanted to give her something not so restrictive. And so here she is afterwards. So we got our rods in there, we get the free flap down, we're all done. Anyone want to comment on where she is, what we've done to her?
Yeah, she looks like she's in a bit of flat back now. I think that looks like that's what's going on here. So she looks like her SVA probably at least 6 to 8 or so, I'd say, roughly.
Yeah, so when I put the rods in, I took some shots and then took them out and played around with trying to compress a little bit, trying to bend a little more. You can actually probably see the result of some of that trying to compensate for this. And I wasn't real happy with where we got her on the table. I agree 100%, thought I left her flat. You know, I see her post-operatively, she's very happy, but you know, probably post-op day 0, I was showing it to my colleagues going, man, I think I left this girl flat. So leg pain's gone, she gets full strength back, her incision heals, her flap heals, she's very happy. And immediately I'm kind of talking to her like, well, let's see how you do. Let's have, you know, when you're standing up and stuff. So here she is standing up. Here she is here she is pre-op to post-op. So clearly, Mike, exactly right. We've made her a little bit of flat. I'm still hoping she's going to retrovert through her pelvis. She's going to, you know, use that remaining disc I gave her and maybe get to a reasonable spot. She's young. So the tumor's gone, but here we are now post-op, and you see the if you go through and look at where I left her, it's not very good, right? So her PI is close to 50. She had a lumbar lordosis going into it at 55. With, you know, around 30 coming from 4 to 1. And then afterwards, here she is with you know, basically 12 from L1 to S1, and she's kyphotic L4 to S1. So I'm not happy with where she is. I see her postoperatively. She's like the most resilient, like best patient in the world. And so every time I see her, I say, you know, I see her walk in, she's a little forward, and I go, you look like you're a little forward. And we go through her x-rays, and I say, I think you're a little flat. I think we can do something here. And, you know, my flap colleagues are going, oh, we did a free flap. We can't go back in there. And the patient's saying, oh, it's a big surgery. I think I'll get there. How about more therapy? And I'm saying, oh, let's just fix this thing. So I sent her to PT for months. And despite both of us, all of us kind of saying, yeah, I think we're getting there. I think we're getting there. She's clearly not getting there, right? If anything, that disc is breaking down more. She's going a little more forward. In fact, that lumbar lordosis I said of 12, I think she was closer to 20 or something when we started, and she just kind of kept, you know, breaking down through that disc. 9 months out, you can see where we are, right? If you, whatever number you want to use, right? Her lumbar lordosis is terrible. It's 12. She's 10 degrees kyphotic 4 to 1. She's, you know, her SVA is 12. She looks like this when she walks, right? She's like a young, normal looking girl who now walks like an old lady. And we've kind of put her through the ringer with therapy, and this is where we are at 9 months. So now what do we want to do? How do we want to handle this? And the flap guys are going, oh, that free flap was so good and it healed. And there's an MRI showing that there's nothing really regrowing. Everything looks really good tumor wise.
Great case, Matt. The good news is you have that L5-S1 disc that you can take advantage of, because did she heal, you would think, across those segments? I mean, it's 9 months. Did you get a solid fusion there, or?
Yeah, good question. Yeah, so she fused through everything, of course. Mm-hmm.
Did you go down to L5 or sacrum, Matt?
Here I'm stopping at, I'm at 5 here.
You're at 5, and she's fused down to the pelvis, or she's fused down to just L5, just 11?
No, she fused through T11 to L5 where I stopped.
Yeah. So
she's got the 5-1 disc. Yeah.
Yeah, which is great. I mean, that's great that she has the L5-S1 disc, because you can take advantage of that. And you know, I mean, how much correction you need to get her back where she's supposed to be? 30 degrees, you think? What's the math there?
Yeah, so she needs a it's like we planned this. You're just walking me through it, Nader. Thank you. So we you know, went through a lot of this, right? So you know, the goal was to get her back to a lumbar lordosis of 55 to 60, and to get most of that, of course, through 4 to 1. And exactly like you said, we're, you know, we still have that 5-1 disc that we can use at this point. So curious to hear what others would do. You kind of already see what I am planning on doing here, which is, or what I did, ALIFs and then posterior column osteotomies using the ProAxis and bringing her down to her pelvis. So anyone else have a different idea about how they would approach this?
Matt,
That's a thought.
was she
Oh, sorry,
completely
Mike, go ahead.
fused at the 9 month mark? Oh, no, sorry. I was just asking if she was, arthrodesed on the CT scan at the 9 month mark.
So she is, but only through the right side at 3, 4, and 4, 5, right? Because I took all that bone off the left side and didn't do anything to the disc on the left side. But she has fused through the posterior column on the right.
Yeah, I don't think there's any doubt that your plan's going to get her to where she needs to be, without a doubt. I guess the big question is there a way that this could be done from all posterior, so you could potentially spare her a multi-level A lift just by doing multi-level PCOs posteriorly. So I guess that would be the big question as to how flexible she is. Once you kind of loosen up her hardware, get her on, get her really kind of sunken in there. So.
Well, for the sake of time, I'll show you what we did, and then I don't want to leave you short on time here, Michael. So so I staged it. I took her in the front first and did an A-lift at 5-1. Really tried to get as much lordosis as I could there, and then I did A-lifts at 3, 4, and 4, 5, and just put chips in there because she was fused in the back. But I wanted to be able to loosen everything up, get some graft in there, and then be able to flex her, be able to extend her, through there when I got to the back. Stage 2, I then had my colleagues raise up the free flap and took her down to the pelvis, and then I did big posterior column osteotomy at 5-1, and then made cuts through the fusion mass at 3, 4, and 4, 5 with a little gap, and then closed them down. And so here is after stage 1. So we got a reasonable amount of correction here from 10 degrees of kyphosis to 20 degrees of lordosis, and then here we are at the end of the case after obviously stage 2, pretty dramatic even clinically looking at her. So here's the CT, right? So you can see I did the big graft at 5-1 and then put just chips, packed chips in here and just freed everything up from the front so I could bend it in the back. And not a perfect cut, but you can see where I made my cuts in the back and then closed her down there as well. And so here she was post-op. I got her back to lumbar lordosis 63 and got most of it through 4-1, and man, what a dramatic difference. I wanted to show this case, although it's a little bit embarrassing where I put her in the middle here, because I am a firm believer that especially as we specialize in other things, tumor or whatever your area is, it's the deformity principles are spine surgery principles, right? So, and the difference in her, I mean, it's crazy how different she is overall, right? I mean, it's just dramatic difference in her and her life. And, she's back to kind of being a normal 23-year-old and happy and can walk around, and her quads aren't exhausted, and her hips feel better now. So anyway, I think that's it. Love to hear if anyone else would have a different approach. Would you go, maybe, I don't know if anyone would go to the pelvis to start. That might have been the thing to do here, but would love to hear any thoughts.
Fantastic case, Matt. These are my thoughts. I mean, this is a fantastic case. You just took care of her and did the right thing, and fantastic correction. Excellent job.
Yeah, it's really nice, Matt. Mike, do you want to share your screen? Yeah, the only thing that I completely agree with you. I mean, when you see these things, you kind of don't want to take a patient back too early, but if you wait a lot longer, they become more stiff, more rigid, and it becomes more difficult. So I just, I bite the bullet and and I have plenty of these complications. I take them back early and fix it, within 3 months, 6 months at the most, because before they have a true arthrodesis,
Yeah.
You did the right thing. Great case.
Man, I think ultimately that's an excellent result. I guess my question for you is what would you do differently to help prevent this the first time around? Would you do something different with the proactive table, positioning? Any thoughts on that?
Yeah, maybe, and I also thought, should I have gone, to the pelvis to start with? I mean, I was taking away, I think part of the problem, you saw I added another rod there. I think part of the problem that I did not anticipate, I think, and encountered late in the day is once I cut away all that, the pedicles in that bone, her spine really flattened out, and I had trouble getting it where I wanted it. And I don't think I anticipated that well, for sure. And you're right. We weren't on the pro-access table, right? We were on a regular table. I really wasn't anticipating that. So I think I might have considered a little more what my construct was, because I think I had her a little better on the table, but spanning that side with no bone with one titanium rod and one screw distal. I'm not a cross-link guy for a variety of reasons that a lot of us aren't cross-link people, but that construct probably wasn't perfect either, right? So that was probably a little weaker than it should have been. So I would have beefed up the construct, maybe used the pro-axis, maybe considered going to the pelvis.
Well, in fairness to you as well, I mean, after 4, 5, 6 hours, however long it sometimes takes to take out these tumors, you'd leave yourself less time and less energy and less reserve to do a huge deformity correction. And obviously you're at the expertise level, Matt, but especially for some junior folks or folks in training, it's never wrong to stage these. If you think, hey, I'm doing a big en bloc resection, it's going to take 5, 6, 7 hours, bring them back and do the deformity surgery. That was great, Matt.
That's exactly right. Yeah, sorry. That's exactly right. The only thing I was going to add is that's exactly right. It's the end of the long day. The flap team's there kind of tapping their foot because I said, hey, we're ready. And I got my final shot and go, I don't know that we're ready. So that's 100% right. Exactly. Yeah,
they're on your back, and it's hard. Great case, and really appreciate the transparency and complications. This is what this is all about. Dr. Galgano is going to close things off for us here with the final case. Dr. Mike Galgano from upstate New York, one of our virtual spine faculty panelists, who's been absolutely a phenomenal teacher, educator, trainer. He's just great to have part of the family. Mike, welcome and thank you.
Ali, thanks for having me. And Matt, we appreciate you sharing that complication, but at the end of the day, that's an awesome sagittal correction, and you got a very treacherous tumor out. So, many applause towards the end result there, which is awesome, I think. So this is a surgical video. I'll show you guys. Hopefully it transmits okay through the virtual world. Okay, so this is a guy I took care of about a week after Super Bowl Sunday, and I'll tell you why that kind of came into play. He's a 53-year-old guy, and he presented with about a week of progressive bilateral lower extremity weakness, right greater than left. And when he arrived to our ED, he basically said that he noticed on Super Bowl Sunday that he could not walk anymore, but he wanted to watch the game, so he basically crawled around his house for a few days. He ended up having bowel constipation for a few days, and he was found to have all the typical long track signs and whatnot when he presented to the upstate emergency department. So let's see if this video plays. So is Dr. Gibbs still on here? Do you want to go through this quickly for us?
All right, so it looks like, what have you got here? What kind of weird sequences? This must be a T1 post-contrast, I think, on the right axial, right? Because you got bright fat, it's not fat saturated. But you have enhancing tumor coming out in widened neural foramen, so that's a long-standing process, like a nerve sheath tumor. It's got some heterogeneous signal in it, though, kind of out peripherally, which makes me think it's got maybe some more aggressive features.
So I'm curious what your thoughts are here. Could you tell from this if there's an intradural component or if this is completely extradural, the component that's within?
It definitely looks intradural. I mean, on this picture, it does. I mean, there's if you look at the intensity, the color, what is this T12? It's like conus level, a little bit above conus level. Is that?
This is at the level of T10, and so that was just.
So you should have a normal cord in there, and you do not.
Yeah, exactly.
So
this is a T1 non-con, just for the sake of completeness. Now, this was an open MRI scan. The guy was severely claustrophobic. This is a T2 that we have here. It looks like obviously there's a cystic component as well. So for the sake of time, I'll kind of jump through the video. I'm just curious what everyone would potentially do in this situation. He presents to us in a rather acute fashion. And, he's not ambulatory. His first couple of days in the hospital, he was being kind of Hoyer lifted from his bed to his chair as we were doing, our standard medical workup and clearance and whatnot. So what do you guys think about what to do here? Would you do this in 2 stages? Would you have the thoracic guys get involved? Or would you try to do this all on a single stage yourself?
Before people start answering, I think we need more diagnosis. I bet Matt Goodwin would agree with me that you probably need a biopsy of that, right? Because that doesn't look like a typical nerve sheath tumor. It could be, but if you're dealing with a malignant peripheral nerve sheath tumor, your treatment might be a little bit different than if it was not. Is that correct?
I agree, but Dr. Gibbs, so what radiographically clues you into the fact that this might not be a benign tumor?
Well, you know, certainly nerve sheath tumors can be intradural and extradural, but the more heterogeneous they are, the more suspicious you will get. And I don't know about the presentation. I'm not sure about that. We always, though, would biopsy them first. If there was any kind of a suspicious feature like that, growth over a very short amount of time, or heterogeneous components, unusual presentation, or patient demographics, maybe is the way to say it.
Sure. So, you know, I understand it is heterogeneous. I was thinking that this was kind of a bit of a cystic component of it. And I was leaning towards the fact that this was probably more benign than a peripheral nerve sheath tumor, which is malignant. I know you said that you've seen them out of the context of a syndromic anomaly like NF1 or NF2. I personally never exist. So anyways, my thoughts were that this was a benign process. So we opted to not biopsy it first. But so what do you guys think about surgical approach here? Is this something that you want to get a thoracic surgeon involved with? My residents were pretty on my back about having a thoracic surgeon, at least in the background for this particular case, given the location. It's in the retropleural space, but it's also in the spinal canal as well.
Mike, if it's I've done a handful of these. If it's a really large chest wall lesion, I'll do it in 2 stages. I'll decompress the back, stabilize, control the spinal cord, then come with a thoracic surgeon to do a thoracotomy. I think this lesion is probably not that big, and you probably have good access to it, dorsally, just in your, maybe if you just go a little bit wider. I would do this from the back, single stage, but there's certainly nothing wrong with coming, also from the side with an access surgeon for a second stage, either same day or the following day. I've done those for bigger ones. This seems to be a little bit more manageable posteriorly. That's what I would do. I would 100% get a biopsy pre-op, just personally.
Yeah, in retrospect, I agree with you guys. I probably should have done that. I did not get a biopsy, and luckily it came back as a benign tumor. But I'll show you guys in the last 5 minutes or so what I did. I have a quick 5 or 6 minute video. So I decided to do this all posterior. I had contacted my thoracic surgeon just to kind of give him the heads up that we were doing this in case we got into trouble. So we ended up instrumenting him from T8 to T12. I knew I had to take a pedicle down. Actually, the tumor did a lot of work for us. I had to take the 9, 10, 10, 11 pedicle. And then I decided to take the T10 rib out, and that's the way I like to get under it, with kind of an angled instrument there. And then what we basically did was we brought the local ultrasound in, and we placed it between the ribs at T10 and T11. We marked out the lateralmost component of the tumor, and then we basically did our rib resection. This is using an ultrasonic bone cutting tool. This is the way some neurosurgeons take it out. I know the orthopedic guys used to like to use a rib cutter, but this is the way I was taught to do it. Doesn't really much matter either way. So we get access here to the retropleural space here. You can see some retropleural fat, endothoracic fascia. You can see the lung beneath there. And this is just us reconfirming one more time that we are in fact lateral enough to the tumor here. So after that, we decided to do a laminectomy at T10. We ended up taking the top of T11 as well. We did complete 2-level facetectomy. And, it was a pretty impressive tumor, I have to say. I wasn't really expecting it to look quite like this. It was bigger than I thought it was going to end up being. You could see how severely rotated the spinal cord is here. So we ended up even taking more lamina inferiorly as well. And what I'm trying to do here is to feel if there's any component of the tumor that is actually going into the intradural space. And, based on the initial radiographic imaging, I can't personally tell. I've been fooled by these before. So basically what we did was I wanted to get good circumferential control of this tumor, for a couple of reasons. I think, it's less hemorrhagic, right? If you get into one of these nerve sheath tumors, they could be pretty bloody. And the other reason is that if this was something that was more malignant, I did want to try to stay, on the outskirts of it, although my suspicions were that it was benign. This is a pretty neat picture you don't get to see too often. This is the true dumbbell nature of this particular type of pathology here, where you can see the foraminal component, extraforaminal component. So I'd like to try to treat these. I've done several of these almost like a meningioma, as the neurosurgeons here would know. We kind of pack the outskirts of the tumor here. After I did that, I brought the ultrasound in to see if there was anything. It's very difficult to tell if there was, because the epidural part went ventral to the spinal cord here. And we could see there was a tiny, tiny, small tumor, which you could see right here, which was coming off one of the thoracic nerve rootlets. So we ended up excising that. And then we kind of were surprised a little bit, and you'll see what I'm referring to. We ended up finding a partial ventral dural defect. Now, we did not do a primary repair of it because it did not look like it was through and through both layers. Right there, you can see that hole over here, but it did not go through and through. So we ended up just putting a piece of dirge in there with some fibrillar on top of it. And then after we excised it, we were able to pay attention to the much larger component of the tumor here. So essentially, we were able to resect this from the ventral epidural space. And once we excise this part of it, you'll be able to see that how the T10 vertebral body was pretty significantly scalloped, as Dr. Gibbs had alluded to. You know, those were there for a long time, and I think it just caused a significant amount of spinal cord compression. Why he started deteriorating as fast as he did, it's a little bit hard to tell. You can see here the T10 nerve root is going through the substance of the tumor. We decided to essentially bipolar it, ligate it, and amputate it off the dura here. As you can see that there's a lateral dural defect here, which we ended up sewing up as well afterwards. You know, so once we get this part disconnected, then we really just need to disconnect the lateral part of the tumor off the runoff of the lateral component of the T10 nerve root once we repair this. Then after that, it's all about retropleural dissection, staying out of the pleural space. And here, getting a right angle here, we'll bipolar. This is the lateral runoff of the T10 nerve root, which we sacrificed here. Now at this point, it's really just kind of dissecting this off the pleura. And what you'll see we ended up doing to help us mobilize, because this was a fairly large tumor, we ended up putting a couple of ovicular sutures into it as well. And my resident was able to kind of help shift the tumor to and fro so that we could get underneath it and dissect it off the pleura without getting a defect here. Anyone have any comments about the technique here, or if anyone would do anything a little bit different here for this case?
Mike, that was awesome. I love the pictures. I love the exposure that you got. I think that's so key for these type of tumors. You really want to see everything. And I think it's phenomenal that you started with the intradural part, because the temptation is just to go right for that what's staring at you. And then what could have happened is you have a little ventral dural defect there that you just would not notice or not see. For some reason, maybe there's something tamponade in the CSF, and you could just be dealing with a disaster, residual tumor and a CSF leak with pseudomeningocele like later on. So that was awesome.
Yeah, I think it's always important for these cases, especially radiographically, if you can't tell if there is an intradural component, you've got to bring the aloca in. If you still can't tell, you've got to do a durotomy. I was fooled. Almost fooled back in January. I had a case and I was 99% certain that there was no intradural component of it. It was a big, and there was a massive tumor in the intradural space. And I'm really glad in retrospect that I did. But a lot of times, even the aloca ultrasound won't tell you definitively, because some of these tumors are in front of the spinal cord. So when you put the ultrasound on it, you can't really tell, is that within the cord or is that in front of the spinal cord? So anyways, the guy made a remarkable recovery. He's back ambulatory now with an assistive device. Unfortunately, he would not let us get a postoperative MRI scan. I'm pretty certain that we had a gross total resection because he's too claustrophobic. I'm hopeful that we can get an open MRI at some point in the future, just to prove that we definitively resected all of it. So that's all I have for you guys.
That's really nice, Mike. Great case, beautiful intraoperative videos and photos. I hope his team won the Super Bowl and it was worth it for him. But,
exactly.
That's fantastic. Listen, thank you guys so much. Thanks for the beautiful cases, great discussions, very educational. So I want to thank you. I want to thank all the presenters on behalf of the faculty, the participants. Thank you so much. Next week, we have Dr. Dr. Khoi Than, one of our faculty co-hosts. He will be hosting a very interesting speaker, Dr. Christoph Hofstetter. Dr. Christoph Hofstetter, who's known to be a pioneer in endoscopy, spinal endoscopy. Many of us, the vast majority of us, don't do much of endoscopy. Some do, but this will be very good. He's an excellent educator. And he was with us on the very, very, very first Zoom virtual spine kind of session, if you will, when not as a speaker, but as kind of one of the participants when a lot of interesting things happened. That was way back then when we got Zoom bombed the very first time we did this. So it's great to have him back. I think we got the technology better now working, and I think we're all in better shape to host him. So Dr. Christoph Hofstetter next week on spinal endoscopy. If nobody has anything to add, thank you, Matt, Alex, Mike, our wonderful faculty co-hosts, and to all the participants. Have a great evening, and we will see everybody next Thursday. Take care, everyone.
Thank you, guys.
Thanks, everyone.